All right, thank you for the opportunity to present on the genomics of bladder cancer for the Urology COVID lecture series. My name is Eugene Pietzak. I'm a attending surgeon at Memorial Sloan Kettering with a focus in bladder cancer. I'm also in the David Salat lab where I focus on bladder cancer translational research. These are my disclosures. This is the outline for my talk. Instead of focusing on naming a bunch of genes and their proteins and sort of overwhelming you with that type of detail, what I've decided to do instead is focus primarily on some of the high yield topics within bladder cancer genomics, with a particular focus on the more clinically relevant aspects of it. So the outline of my talk will focus initially on the highly prevalent chromatin modifying gene mutations and the relevance of that, focused on some of the so-called actionable targeted therapies within bladder cancer, focusing in particular on FGFR3, the furthest along in development, and then ending with a segment focused on DNA damage repair genes and their role both in muscle invasive bladder cancer as well as non-muscle invasive bladder cancer. So I hope that this is highly relevant and of interest to the people watching this. So just in the way of some brief background, what I'm going to do is present a bunch of what are called oncoprints. And just if you're not familiar with these, so they don't seem overwhelming, it's basically just a graphical method to display what is complex genomic information. And what it really is a way for the researchers to tell a story. And that story includes what's being shown on the graph, but also what's not being shown on the graph as well. So you be mindful of that. So to interpret these oncoprints, basically each column represents an individual patient or individual tumor. And so each one of these columns over here, so this is an example where in this oncoprint, the clinical and pathologic details are presented up top. The actual genomics, genomic alterations that are seen are found here. And then the type of genomic alterations, which could vary based off what the oncoprint is, but the legend is typically also presented. So for example, this first tumor over here, this is a patient where I guess there wasn't information on whether or not they had BCG treatment or disease recurrence. This is probably a patient treated with an immediate cystectomy. They had an FGFR3 amplification, and then they had an ERBB3 recurrent missense mutation. And then the next patient over here, dark over here means they received BCG, they did not have a recurrence, and they have a FGFR3 fusion, and so on. So this oncoprint basically gives you information about what what the genomic background is for each individual tumor, and as I mentioned, it sort of is there to tell a story. So most of my talk is going to focus on two primary papers. This is from the large TCGA, the Cancer Genome Atlas effort, which is of muscle invasive, neoadjuvant naive muscle invasive tumors. In the initial paper, there was 131 tumors that were sequenced. Now there's over 400 that are presented in this most recent 2017 publication. And this is just the representative oncoprint landscape that is shown over here. The other one is a paper from our group at MSK, which used targeted exome sequencing of non-muscle invasive patients to display the genomic landscape of non-muscle invasive disease. And this is the relevant oncoprint, which I'll walk you through as we go through the details. And so just in this particular oncoprint, it includes low-grade patients, low-grade TA tumors, high-grade TA, high-grade T1, as well as some muscle invasive tumors just for comparison purposes. Notably, what is missing from this is carcinoma in situ. This is all tissue-based approaches, and because of the scant cellularity of carcinoma in situ, there wasn't high yield in that, so it's not included here. As I had mentioned, this is the story that we're telling, and it's mostly a papillary non-muscle invasive tumors here. Okay, so onto our first sort of story. It's the importance of chromatin remodeling genes in bladder cancer. And so the chromatin remodeling genes are basically responsible for either expressing or repressing genes by modifying histones and modifying the chromatin in packaging. And so there are what are called writers as well as erasers and so-called readers, which could either increase transcription or suppress transcription in a very tightly regulated way. So this is essentially sort of these genes lead to epigenetic modifications, which are particularly relevant because they're quite pervasive in bladder cancers. I'll show you in the subsequent slides. And a mutation in one of these genes could have multiple downstream effects. And so again, this is the TCGA muscle invasive specimens. And as you can see here, some of the most common alterations are in these chromatin remodeling genes over here as well. And there's additional ones that aren't highlighted here, but they are quite pervasive throughout muscle invasive specimens, as well as in non-muscle invasive specimens as well. So the importance is quite interesting. Recently, there's been 2 science papers which basically did whole exome sequencing of histologic normal appearing urothelium from patients that died from other causes at autopsy, did not have bladder cancer, as well as patients that had bladder cancer. So 2 different series, one in bladder cancer patients and one in non-bladder cancer patients. And what they found is in both those series that in histologic normal appearing urothelium, there was a high rate of somatic mutations within these chromatin modifying genes, and that these led to what's called clonal expansion. And eventually, in the case of malignant transformation, a second tumor mutation would have occurred before the tumor formed. So what this is suggestive of, these chromatin remodeling gene alterations are probably one of the earliest mutations that occurs in bladder cancer. And generally, there's a second hit that occurs before there's malignant transformation that occurs. So this gives us some insight into the pathogenesis for which bladder cancer develops, and some insight into that disease process. Interestingly, because obviously the bladder is involved with collection of urine, that provides the potential opportunity to do sequencing of the urine cells that are shed. And you can look into what's called cell-free DNA within the urine itself. So these are DNA fragments that are captured within the urine. And in this publication from the Stanford group over here, as you can see, patients with bladder cancer very commonly will have tumor mutations within the urine themselves, where healthy adults generally do not have any alterations present. And what is interesting is in patients that have detectable, or patients with bladder cancer who have detectable urine tumor DNA present, they're at higher likelihood of recurring on surveillance cystoscopy. So this suggests that screening for these chromatin modifying genes, which are again very highly pervasive within bladder cancer, could be used potentially as a screening test to detect bladder cancer in, say, a hematuria workup compared to a healthy adult. And it could also serve as an indicator for surveillance, potentially avoiding the need for an invasive office cystoscopy and monitoring patients for what's called minimal residual disease after their TURBT or treatment to predict whether someone will be more likely to recur. And compared to, say, urinary cytology, which are very good, very sensitive for high-grade tumors, but not very sensitive for low-grade tumors, something like urinary tumor DNA may be very robust in also detecting low-grade malignancies. ARID1A, which is a chromatin modifying gene, just to highlight, and at least our investigation into looking at predictors of response to BCG, ARID1A was the only gene that we found out of 341 that we assessed that was associated with a risk of recurrence with BCG, certainly earlier recurrence, even when correcting for multiple comparisons. This appears to be independently validated at this point in time. However, sort of the functional ramifications of this are still unknown and still being investigated, and this work is ongoing. In patients with metastatic disease, ARID1A appears to be associated with a favorable response to immune checkpoint inhibitor, which is quite interesting because BCG and immune checkpoint inhibitors are basically two different types of immunotherapies, but this is in two independent clinical trials of immune checkpoint inhibitors in which patients with with a mutant form of ARID1A tended to do better with immune checkpoint inhibitors in the metastatic setting in these two independent cohorts. And then in some publications looking at histone deacetylase inhibitors, which again affect sort of the chromatin structure, ARID1A may be a particularly relevant target for that. And there's been, at least in what is clear cell ovarian cancer, ovarian clear cell carcinoma, ARID1A mutations are very highly prevalent in that. And there's multiple studies showing that there's potential what's called synthetic lethality, where if you treat with a specific drug in a specific mutational context, that those tumors are exquisitely sensitive to such treatments. And there's numerous ones that have been investigated in clear cell ovarian cancer. Just to sort of highlight one of them is an EZH2 inhibitor, where basically when you have ARID1A loss, it increases the overexpression of EZH2, which again works on the transcriptional level on the chromatin, and then basically unopposed because ARID1A is lost in those tumors. But if you treat with a EZH2 inhibitor, then these tumors are exquisitely sensitive to such treatment. So ARID1A may potentially be a therapeutic target in non-muscle invasive disease, potentially in more advanced settings as well. And there's numerous other potential agents that could potentially be tried in ARID1A mutated tumors. So the take home for the chromatin modifying gene portion is they are highly prevalent. The data suggests that these are early events in bladder cancer carcinogenesis, and that detection of these alterations in the urine may serve as a potential screening and or surveillance biomarker, and then these may be potentially actionable alterations that could have a therapeutic implications. So moving on to targeted therapies in bladder cancer. Within bladder cancer itself, there is numerous potential therapeutic opportunities, and there are numerous drugs as listed in these cartoon diagrams and the list of open investigations down here. And so this is obviously of much interest and excitement. This is some data from the MD Anderson group looking at their phase 1 clinical trial cohorts. And as you can see, just highlighting over here and looking at genomically matched clinical trials, two of the most common are FGFR3 and ERBB2. ERBB2 is also known as HER2, and so very common in breast cancer as a therapeutic strategy. And so potential opportunities also in bladder cancer as well with ERBB2. I'm going to focus this segment primarily on FGFR3. As you could say here, it's highly pervasive within this phase 1 protocol from MD Anderson. And if you look across all stages for bladder cancer, FGFR3 alterations are very highly prevalent within low-grade TA tumors, also highly prevalent in high-grade TA tumors, especially in those without carcinoma in situ. There's a general inverse relationship. CIS generally does not have FGFR3 alterations associated with it. And as you go up in stage to high-grade T1, you'll notice that there's less. There's 40% essentially in high-grade T1. And then when you go to muscle invasive as well as metastatic, it drops down to about 20%, as could be seen over here in this oncoprint here. What's exciting about this is erdafitinib has been the first FDA-approved targeted therapy for bladder cancer. It was approved in April 2019. This is for patients with metastatic urothelial cancer with a FGFR3 mutation or fusion, or an FGFR3 fusion. These patients, its approval is after patients have progressed after platinum-based chemotherapy. including if they've previously received immunotherapy. What's interesting, though, is that although the objective response rate is fairly high, these are in genomically selected patients. So all patients had either FGFR2 or 3 alteration. However, obviously not all patients responded. So there's some complexity to the genome. There's co-alterations, other mutations that may be affecting response, and only 3% had a complete response. So this is sort of a bit of a different story than what you see with immunotherapy, where these patients essentially may have a more durable tail, survival tail with immunotherapy. The other notable thing for targeted therapies, systemic targeted therapies like erdafitinib and other targeted therapies, is that this is a tyrosine kinase inhibitor, and so side effects are not infrequent and need to be managed. And so these are things that we need to be mindful of with this. But there's much excitement. Erdafitinib is certainly not the only FGFR3 inhibitor in ongoing investigations. BGJ was published a couple of years ago. There's numerous other FGFR inhibitors as well that are under active investigation, and this is becoming an increasingly more and more exciting area, looking at targeted therapies. In part also because there is some emerging data that suggests that FGFR3 alterations are associated with a immunosuppressive tumor microenvironment. And this sort of lends itself potentially to combinations with immune checkpoint inhibitors. So this is some data from the University of Chicago group reanalyzing the TCGA that basically found a relationship between FGFR3 alterations and what's called the non-T cell inflamed tumor microenvironment. This is some additional data looking at some mouse models of bladder cancer, amongst some other investigations in looking at subtyping, again showing that FGFR3 alterations are associated with a somewhat immunosuppressed tumor microenvironment. And then this is data from the Cornell group looking at upper tract urothelial cancers, where in upper tract urothelial cancers, FGFR3 alterations are quite common, even more so than in certainly muscle invasive tumors, and potential opportunity for FGFR inhibition in reversing some of the immunosuppressive tumor microenvironment that was previously reported. So this is a working hypothesis and an area of an active investigation amongst many labs, and something that is of particular relevance clinically. And I think we'll be seeing more and more of this in the future. I also just want to highlight that actionable alterations are not just prevalent in muscle invasive and metastatic patients, but also potentially in patients with high-grade non-muscle invasive bladder cancer. This is actually the example of the OncoPrint that I had given at the beginning intro slide, but this is looking at patients with high-grade non-muscle invasive bladder cancer. And as you can see here, about 75% of them have at least one potentially actionable alteration. And notice the mutually exclusive relationship between FGFR3 alterations and ERBB2, HER2 mutations over here, where they're non-overlapping here, which contrasts to PIK3C mutations, CA mutations, where those are co-altering with both FGFR3 as well as ERBB2. And just of note, of the patients treated with BCG, patients with FGFR3 as well as ERBB2 do as poorly as patients with wild type tumors. So this may be a potential avenue of further investigation. However, as I had mentioned, we need to be mindful of the fact of the systemic toxicities that may be present. There may be opportunities for intravesical treatments, intravesical targeted therapies. There's a lot of active investigation into this area that is ongoing, and more to certainly explore here. But I think in the future, this will be something of particular relevance. I just want to bring up the fact that there's not much time in this lecture to go over it, but with regards to what are called the molecular subtypes of bladder cancer. Now, these are gene expression based off RNA profiling, so RNA-seq. This is from the TCGA. where they basically designate particular subtypes. These are sort of derived or borrowed initially from breast cancer subtypes, so luminal and basal subtyping. And there's been a lot of active investigation from multiple groups into these RNA expression-based molecular subtypes. I just want to highlight one in particular, which is called the luminal papillary subtype, which are enriched in FGFR3 mutations over here. And there is some, at least preliminary data that suggests that these patients may be less likely to respond to chemotherapy. And some people argue that potentially they may benefit more from an FGFR3 inhibitor than from neoadjuvant chemotherapy. This still needs to be prospectively validated, but sort of a different take on a similar concept of trying to identify patients for targeted therapies like FGFR3 inhibition. So the take homes from the targeted therapy are there's robust opportunities available in bladder cancer due to the numerous potential targets. Erdafitinib is the first FDA approved targeted therapy, but we expect that other FGFR inhibitors as well as other targeted therapies will likely be approved in the near future. And this is obviously a very exciting area. I do think there's a lot of excitement potentially for the various combinations between targeted therapies and immunotherapies in the future as well. But we need to be mindful that these drugs do have a cost to them, and they do have potential risks, usually systemic side effects. And as I had mentioned, patients with metastatic bladder cancer are going to be far more accepting of some of those side effects than potentially patients with non-muscle invasive bladder cancer. And so we certainly need to be mindful of that. And then, due to the toxicity, it's unclear how long patients could potentially stay on some of these treatments. So we need to also do a little bit better as well, getting more selective treatments that are targeted specifically at the mutation with less off-target effects. And then moving on to the role for DNA damage response genes in muscle invasive bladder cancer, with the subtitle that taking more of a precision medicine approach to neoadjuvant chemotherapy. So the current treatment paradigm for muscle invasive bladder cancer, as I'm sure you're all familiar with, is basically to treat patients with neoadjuvant cisplatin-based chemotherapy if they're eligible and able to get cisplatin therapy. That provides about a 5 to 7% survival advantage over cystectomy alone, and then they proceed with cystectomy afterwards. However, as I'm sure you're all aware, that survival advantage is only really seen in chemotherapy responders, and patients who are non-responders to neoadjuvant chemotherapy may potentially be harmed by delaying curative cystectomy. And so this is the initial SWOG trial that is the most supporting of neoadjuvant chemotherapy. This is some data from MSK looking at downstaging after neoadjuvant chemotherapy, and as can be seen both in the SWOG trial with PT0 rates, these patients do very well long-term compared to patients with residual disease. And in the MSK experience, this is looking for any patients with downstaging to less than muscle invasive disease compared to patients with residual muscle invasive disease after neoadjuvant chemotherapy. There's obvious split between these curves here. And so the question for these patients who do very well with neoadjuvant chemotherapy is, this is the sort of the frequent question that gets asked from a patient when they don't have any residual disease after chemotherapy and you remove their bladder at cystectomy. And it's common to sort of give them, good news, there's no residual cancer present and you have an excellent chance at long-term durable survival. And it's not infrequent for patients to ask, why, if there wasn't any cancer left in my bladder, then why did you need to remove it surgically and leave them either with a neobladder or a conduit, etc. And so that is sometimes a difficult question to answer, but the fact of the matter is, based off our current abilities at doing clinical staging, whether it's with integration of MRIs or even post-chemotherapy TURBTs, our post-chemo clinical restaging protocols with that alone are quite inaccurate. So there was a SWOG study from several decades ago at this point where patients were presented with the option of immediate cystectomy versus observation. Somewhere around 40% of patients who had clinically no evidence of disease who underwent a immediate cystectomy were found to have residual muscle invasive disease. And this was seen in recent work, both from the Hopkins group, as well as the group at Fox Chase as well. So unfortunately, despite our best intentions, clinical staging alone, even when TURBT is performed, is frequently inaccurate. And so the question is, can we use molecular biomarkers for cisplatin sensitivity to identify patients who may potentially be managed with just TUR and neoadjuvant chemotherapy alone, and potentially safely avoid the need for cystectomy and avoid the need for chemoradiation? And so these investigations included what was called an extreme phenotype analysis, basically taking patients who did really well with neoadjuvant chemotherapy, had complete pathologic responses, and taking patients who did unfortunately poorly with neoadjuvant chemotherapy with residual muscle invasive disease, and comparing their genomic profile. And so this is an investigation from Ellie Van Allen's group, as well as Jonathan Rosenberg, Ellie Van Allen at Dana-Farber and the Broad. And so whole exome sequencing of 25 responders and 25 non-responders. And interestingly enough, when they compared the genomic profiles for responders versus non-responders, what was found is that responders to neoadjuvant chemotherapy had an enrichment in this gene called ERCC2, a DNA damage repair gene. So ERCC2 is a nucleotide excision repair pathway gene. It's actually involved, not surprisingly, in repair of cisplatin-induced DNA damage. And so it is essentially a helicase that unwinds DNA to allow the DNA repair mechanisms to come in. And so if ERCC2 is present within the tumor itself, the tumor is able to repair any of the damage from cisplatin and continue to grow as a tumor. However, if there is ERCC2 loss and there is impaired DNA damage repair, then this results in sort of the tumor cells being overwhelmed by the DNA damage, and it results in cancer cell death. So again, sort of the concept of synthetic lethality, where if an ERCC2 mutation is present, then cisplatin may potentially almost act as a targeted therapy and overwhelm and lead to cell death. So ERCC2, as seen here in the TCGA, is present in about 12% of all muscle invasive tumors. Interestingly enough, it is enriched in patients responding to neoadjuvant chemotherapy in that Ellie Van Allen paper, but it's present in about 12%, 10% or so in unselected cohorts of muscle invasive bladder cancer. And it is a gene that appears to be unique in bladder cancer. It's most commonly mutated in bladder cancer compared to other cancer types profiled by the TCGA. In that publication, they did some in vitro experiments that basically showed that functional validation with ERCC2 missense mutations, where they are more sensitive than the wild type cell line to cisplatin, especially increasing concentrations of cisplatin. So that provided some functional validation. It's also noted that tumors with ERCC2 missense mutations have higher mutational burden overall, as seen over here, and that this may be potentially giving these tumors a selective growth advantage. So the lack of repair capabilities from ERCC2 loss allows these mutations to accumulate more and more in these tumors. So these tumors may potentially be more aggressive at initial presentation, but then that could be therapeutically exploited and then become more as they're more sensitive to cisplatin chemotherapy. So a very interesting concept. And so how true is this? And so this is some clinical validations of ERCC2 in patients with muscle invasive bladder cancer. This is in the Fox Chase cohort of patients. And so the presence of an ERCC2 missense mutation, these patients did exquisitely well with dose-dense MVAC compared to patients who did not have an ERCC2 missense mutation. This is in the Dana-Farber and MSK discovery cohort. It was from the Ellie Van Allen paper. And in this paper, again, patients with ERCC2 missense mutations did exquisitely well. Obviously, it's not perfect, not everyone. Some patients did recur. However, they did much better than patients without an ERCC2 missense mutation. This was further investigated in a phase 2 clinical trial here at MSK as well as at UNC, looking at dose-dense gemcitabine and cisplatin. And so in this clinical trial, patients actually got 6 cycles of dose-dense gemcitabine and then proceeded with standard of care cystectomy. And then retrospectively, the tumor tissues were looked at to see if we could find predictors of response to neoadjuvant chemotherapy. And in this investigation, again, ERCC2 was enriched in the responders to neoadjuvant chemotherapy. Other DNA damage repair genes also appeared to be enriched in patients responding. And so the specificity of this panel of genes was about 92% for identifying pathologic complete responses, or I should say pathologic downstaging, because they also included patients with CIS of the bladder, and the positive predictive value was 88%. And just as previously seen, patients with DNA damage mutations did exquisitely well long-term compared to patients with DNA damage repair gene wild-type profiles. So this led to the development of an alliance cooperative group trial, which initially was only looking at dose-dense gemcitabine, but has since been modified and is now essentially allowing for investigator choice of gemcitabine, either standard treatment or dose-dense gemcitabine for 6 cycles. A couple of things to note for this trial. Unlike some of the retrospective investigations looking to see if we could clinically restage patients after neoadjuvant chemotherapy, in this trial, these tumors are carefully selected, or these patients and their tumors are carefully selected. So it's limited, basically minimal carcinoma in situ, only 1 muscle invasive tumor, and the tumor needs to be relatively smaller in size, no tumor greater than 5 centimeters. It's basically for patients who, sort of the optimal candidate potentially for bladder preservation. These patients are getting treated with their neoadjuvant chemotherapy gemcitabine cisplatin regimen of choice. And while they're receiving neoadjuvant chemotherapy, their tumor is undergoing targeted exome sequencing panel for one of these genes over here, looking for deleterious somatic alterations. And then based off their molecular profile, if they have a DNA damage repair gene alteration present, then they're undergoing a post-chemotherapy TURBT, and it is described as aggressive because we want to make sure that there isn't any deposits that are subepithelial. And if there is no residual invasive disease present, then those patients are eligible for bladder sparing basically by surveillance cystoscopy. So avoiding radical cystectomy and potentially avoiding the need for chemoradiation. If there is any residual invasive disease, then they proceed with radical cystectomy. If they have a DNA damage wild type tumor, then they'll proceed with radical cystectomy, or they could opt for chemoradiation. And so this is, sort of a biomarker driven trial based off some pretty good preclinical as well as translational research leading up to it to prospectively validate this concept of whether or not we could prospectively identify patients who will respond to neoadjuvant chemotherapy and potentially avoid the need for radical treatment with either surgery or chemoradiation. So the primary endpoint for this needs to be a very high bar because, as we've discussed, these patients who respond to neoadjuvant chemotherapy do very well following radical cystectomy. So the primary endpoint is recurrence-free survival at 3 years, but even more importantly will be the durability of response. So I would expect, just like patients treated with chemotherapy and radiation, that recurrences within the bladder will be identified. But if those patients are able to be spared and salvaged with further intravesical treatments and avoid, on what potentially could be a preventable bladder cancer death, then this could be a very viable option going forward, where we're using genomic profiles to guide patient care. And so, there are other potential biomarkers of cisplatin sensitivity as well. This is a panel from the Fox Chase group looking at ATM, RB1, and FANC-C. And this led to their RETAIN trial, which they recently just presented in abstract form at GU ASCO, some of their preliminary data looking at this. And this is a similar concept. Notable differences within their panel of genes. They're also including RB1, which there's a little bit of controversy about whether or not that's actually a DNA damage repair gene. It's also one of out of all the genes that are listed here, it's the most commonly mutated in bladder cancer. So we'll have a better idea about whether or not RB1 is actually sensitizing to cisplatin chemotherapy based off the results of this trial. But essentially, patients are treated with neoadjuvant chemotherapy, dose-dense MVAC, and then they undergo their post-chemotherapy TURBT. And if there's no residual disease and they have a mutation positive, then they undergo active surveillance, where if they have a mutation present and they have some residual non-muscle invasive disease present, then the patient decides how they would like to proceed. And the same if they have a complete clinical response without the presence of a mutation, one of these mutations here, then they decide between either intravesical treatment, chemoradiation, or cystectomy. And then for anyone with T2 disease, or T3 or higher, they undergo treatment with cystectomy or chemoradiation. And so, these are just two examples of biomarker-driven clinical trials, and I think we're all anxiously awaiting to see how the results of these trials go. As I sort of alluded to before, there are gene expression RNA-based subtypes, molecular subtypes of bladder cancer. Again, I don't have too much time to go into the detail of that, but essentially there are these basal subtypes, which some think that they may be more sensitive to neoadjuvant chemotherapy compared to the luminal or non-basal subtypes. And an example of a potential cooperative group type study that has been discussed and I believe is still under consideration is based off this biomarker analysis, where essentially combining the DNA damage repair gene mutational status along with the presence of these molecular subtypes. So patients with basal or DNA damage mutations may proceed with neoadjuvant chemotherapy prior to radical cystectomy, where patients with a DNA damage repair gene wild type tumor, or a patient with a luminal subtype of tumor who are thought to not respond well to neoadjuvant chemotherapy would then proceed directly to radical cystectomy. Again, I emphasize that none of these have necessarily been proven prospectively, and so these are for clinical trial purposes only. And I don't think that either the molecular subtypes or DNA damage repair gene status should be guiding current patient management, and we should be enrolling these patients in clinical trials, so we could further advance the field. But yeah, I just wanted to highlight some of the ongoing ideas or concepts that are on the cusp of becoming clinical trials. And so what about DNA damage repair genes within non-muscle invasive bladder cancer? So they are actually also quite pervasive, but predominantly in high-grade non-muscle invasive disease. And so if we look over here, ERCC2, that same gene that we were just discussing on the previous slides, very common in high-grade non-muscle invasive bladder cancer, fairly uncommon in patients with low-grade non-muscle invasive bladder cancer. And if we look at mutational burden, which is the total number of mutations based off the megabases of DNA that's actually sequenced, we see that high-grade non-muscle invasive bladder cancer is actually quite similar to muscle invasive bladder cancer in terms of a higher tumor mutational burden, and it's notably higher than low-grade non-muscle invasive bladder cancer. And for tumors with a ERCC2 missense mutation or a DNA damage repair gene alteration in general, they have a much higher tumor mutational burden than tumors that are unaltered in the high-grade non-muscle invasive disease patients. This was also further validated by the Dana-Farber group, looking at their group of 126 high-grade tumors. Again, ERCC2 is quite prevalent in high-grade non-muscle invasive disease, and it is again associated with a higher tumor mutational burden, similar to muscle invasive tumors and much higher than low-grade non-muscle invasive tumors. And again, if you have a DNA damage repair gene alteration, the tumor mutational burden is higher than if you are a DNA damage repair gene wild type tumor. And so this is pretty interesting because we know that bladder cancer, and this is muscle invasive specimens, have a very high mutational burden, which is thought to lead to potential formation of tumor neoantigens that could be recognized by the immune system. And this is particularly relevant in immune checkpoint treated tumors. And so if you look at increasing mutational burden on the x-axis here compared to the objective response rate for immune checkpoint inhibitors, and you look to see as tumor mutational burden increases, the objective response rate amongst multiple cancer types increases as well. And urothelial cancer is right over here, sort of dead center, right along this line present. And it's thought that patients responding to immune checkpoint inhibitors are so-called have that benefit of the long tail of survival. And so this is particularly interesting, especially since most non-muscle invasive high-grade tumors are treated with BCG, at least when it's clinically available and not in a time of shortage. And so we know that BCG is a non-specific immunotherapy. And we know that BCG actually is the original immunotherapy. And for a very long time, we know that it has a long tail, just like the immune checkpoint inhibitors. So this is from Dr. Lamb and colleagues from 1991, where they comment on this long tail from BCG compared to intravesical chemotherapy treatments. So this is quite interesting. When we looked at our experience with in high-grade non-muscle invasive specimens, as previously mentioned, ERCC2 missense mutations are associated with higher mutational burden. And these mutations, just like in muscle invasive disease, actually cluster around the helicase domain, where it's particularly responsible for unwinding DNA. So very similar mutations. And this is not statistically significant, but as we increase our numbers, this is increasing association we're interested in. But it appears that that tumors with ERCC2 mutations may be more sensitive, or DNA damage repair gene alterations in general may be more sensitive to BCG. This needs further investigation and further validation, but an interesting hypothesis is currently being generated. And if we look from data from the Dana-Farber group again, this is looking at 62 high-grade T1 tumors that were treated with BCG, and they divided their cohort into 3 groups. One was good outcome, those that had recurrence and those that had progressive disease. If you look at the patients who had a good outcome, which they defined as no recurrences with greater than 4 years of follow-up, they found that a good outcome was associated with higher tumor mutational burden, ERCC2 missense mutations, even when they adjusted for tumor mutational burden, as well as mutational signatures, both APOBEC as well as ERCC2, which are associated with higher tumor mutational burden. In ERCC2 associated mutational signatures, not surprisingly, are also associated with ERCC2 missense mutations. And so again, all sort of suggesting that DNA damage repair genes may be associated with a favorable response to BCG. Find this particularly interesting because in our investigation, looking at patients who presented with de novo muscle invasive bladder cancer compared to patients who were initially diagnosed with non-muscle invasive disease, treated with BCG, and then unfortunately progressed to what we're calling secondary muscle invasive bladder cancer. What you'll see here is in 2 independent cohorts of patients, there was a statistically significant difference between the frequency of ERCC2 missense mutations, which are associated with sensitivity to cisplatin chemotherapy in patients with primary muscle invasive disease compared to those with secondary muscle invasive bladder cancer. And then in a prospective validation cohort, we saw this same findings with 17% ERCC2 missense mutations in patients with primary muscle invasive disease, but none seen in patients with secondary muscle invasive disease. And this certainly has potential clinical implications. And as we've discussed previously, these genes are associated potentially with response to neoadjuvant chemotherapy. And so it shouldn't be surprising that when we looked at our clinical outcomes for these patients, again, small numbers and needs to be validated certainly prospectively, but patients with secondary muscle invasive bladder cancer had worse outcomes with neoadjuvant chemotherapy compared to those that present with primary muscle invasive disease. And this aligns with a previous study from 2004 that looked again at primary versus secondary muscle invasive disease that found that in this cohort, 40% were treated with systemic chemotherapy, but they found that patients with secondary muscle invasive bladder cancer did worse compared to patients with primary muscle invasive disease. And this sort of is a little bit provocative because it suggests that potentially that BCG immunotherapy, which may be very selective or sensitizing to ERCC2 missense mutations, may result in what is called clonal selection. So basically the ERCC2 clones are eliminated by BCG, and then when they recur, they tend to be ERCC2 wild type tumors and more likely to be resistant to subsequent systemic chemotherapy. Again, needs to be prospectively validated. And it's also very possible that tumors that progress to secondary muscle invasive bladder cancer may not have any ERCC2 missense mutations. And so this needs to be further investigated. And this is an area of certainly active investigation for my group as well as some other groups as well. So at this point, I'm going to conclude my talk. Hopefully you guys were able to last this entire time. I know that sometimes these talks can be a little bit boring, but I tried to focus on some of the clinical implications, so it's a little bit more interesting. But the take homes that I wanted to leave you guys all with is that chromatin modifying genes are highly pervasive across all stages and grades in bladder cancer. And this could have potential implications for urine-based screening and surveillance approaches. They also could be therapeutic opportunities for drugs, drug development. And there is numerous other potentially actionable alterations in both muscle invasive as well as non-muscle invasive bladder cancer. I focus primarily just on FGFR3 since it's the first FDA approved targeted therapy, but there's certainly more targeted therapies to come in the near future. And then, we quickly went over some of the data on the DNA damage repair genes that may be potentially an avenue to predict who will be excellent responders to neoadjuvant chemotherapy and could potentially avoid the need for radical cystectomy or chemotherapy. And then finally, we briefly discussed some of the potential implications for DNA damage repair genes in predicting BCG response, as well as potentially in non-muscle invasive progression to secondary muscle invasive bladder cancer. Thank you very much for your time and your attention. Please feel free to reach out to me if you have any questions or if I could be of help in any way. And then please also fill out this survey so we can get some feedback. And I want to thank the organizers for the Urology COVID lecture series. I think this is a wonderful way during these very challenging times for the residents and fellows to keep up to date on what's going on in urology. I hope everyone is happy and healthy and remain safe, and hopefully we'll be able to get some meetings in the near future. Please feel free to reach out to me at any time. Thank you again for your time and attention.